Hello, my dear candidates. How are you all? Hoping all are well and doing practice. Though I started dermatology mock, and today or tomorrow I'll post the surgery mock also. So hope this today orthopedic session and vascular surgery short session will be helpful for more whose exam very near and knocking the door. So my dear candidates, actually from myself, I orthopedics is a chapter. It's really little bit tougher, but the thing is that we have to know the basic. Even if anyone want to don't do the task for orthopedics, it's okay, acceptable. Cause one or two questions we have to face, but I am covering all. If we have a clear concept, we can easily mark of those questions. So today more question practice, more discussion. So I'm starting my session, though we are not adding, they'll join later. So general rules. So in orthopedics, general rules is that any fracture under 6 years, will be treated by cast with close reduction or close reduction by this positive support and pressure, okay, except lateral condylar fracture. So regarding the close reduction support except lateral condylar fracture, so we have to remember that below 6 year we have to do fracture management by cast and close reduction, or if needed CRPP. That's it, because they post this CRPP. Another way, emergency or compartment syndrome, septic arthritis, open fracture. We have to remember these are the emergency variant question. Compartment syndrome, septic arthritis, open fracture. Okay, we have to do CT scan. It's a short summary. We have to do CT scan if any interarticular fracture present. Check NAV status means we have to check this vital structure, like after reduction of fracture of this location, we have to check this NV status means vital status of the patient, and nerve study and nerve function and nerve velocity. So my dear candidates, after doing reduction of fracture, we have to check the nerve function or nerve velocity, or you can say the functional status. No debridement. In emergency, a patient come to your hospital after accident, we can't do debridement. Understand the drug of choice. So if there is definite treatment delay until physiology have improved. So say a patient come to your hospital with fracture, we have to manage first vital status. A, like patient come to your hospital with ARDS, there's rupture or break or fracture of the ribs, okay, or pneumothorax or failure, and there's acute inflammatory windows there. So I have to stabilize the patient first, then definitive management. So initially what we have to do, view the X-ray for the joint assessment. Then if there are an infective sign, the gold standard for the infection is the aspiration. We have to do observation alone. We have to do observation alone. If non-ambulatory high risk surgery, if it is non-ambulatory high risk surgery, we have to do observation alone. Though I will discuss more question today. If anyone do wrong, no issue, because orthopedic is not so easy to remember. So first question, I hope try to practice. So first question will be discussed with me, Dr. Anjana.
Good evening, ma'am.
Good evening.
19-year-old football player is seen in the emergency ward with severe knee pain after being hit by a tackler while running. Which of the following findings on the physical examination is most sensitive for anterior cruciate ligament injury? Posterior and positive anterior drawer test, excessive varus to the of the varus laxity of the knee, locked knee, positive latchment test, and positive drawer test. So ACL tear, ma'am, I think anterior drawer test should be positive.
Yeah, anterior drostis is the positive. So the thing is that you see a patient emergency come to your hospital with severe knee pain, right? So
Yes.
see the structure, or it will be helpful. So severe knee pain after being hit by a tackler while running. While running, the patient hit by a tackler. So which of the following findings on the physical examination is most sensitive? So you see this Lachman's test, anterior cruciate ligament injury. We have to stabilize the femur with one hand and with other hand pull the tibia anteriorly and posterior against the femur. So it's the Lachman's test more sensitive. Okay, doctor? It's a
Okay.
clean cut exam, same scenario you will face. If any question anyone can face, there's 30 questions today I'll discuss. So the same scenario you will face in the exam. So it is the answer is the positive Lachman's test, right? Clear? Anterior cruciate ligament injury, we have to do Lachman's test. Okay. Second question, doctors will be discussed with me, Dr. Ikra. This is a common exam question. It's a first question is not so common, but second question is a common.
Assalamu alaikum, ma'am.
Alaikum assalam.
A 13-year-old male patient presents with complaints of bilateral knee pain. He notes that the pain is increased with jumping, squatting, or running up a flight of stairs. No other joints are affected. On physical examination, he has tenderness to palpation directly over his tibial tubercles. Lyme's disease, stress fracture of tibial, plateau, Osgood, Schalter disease, and patellar tendinopathy. And the last one is the Sending Larson.
Sliding Larsen-Janssen syndrome.
Yeah.
Sliding Larsen-Janssen syndrome. Okay. So,
Ma'am,
Dr. Ikra, yeah, tell me.
ma'am, its answer is C.
Yeah, it's Osgood-Schlatter syndrome, right? Or Osgood-Schlatter disease. So why? Because there's a pain on jumping,
Yeah.
squatting, running, and the age is very young. It's 13 year, and you see there is a this knee joint. There is erosion. Of, yeah,
Yeah.
there's a tuberosity that's eroded,
Yes,
right? So
yes,
the
ma'am.
explanation, thank you, Dr. Zikra, you done well. So Osgood-Schlatter disease, tibial tubercle apophysitis. So is there is I said only erosion. You see there is a apophysitis. So see the erosion mark, apophysitis. Okay. So osteochondrosis, tibial tubercle apophysis. So osteochondrosis or fraction apophysis of tibial tubercle. So It's the Osgood scatter disease. Just remember, there is apophysitis of tibial tubercle. Actually, if you ask me, ma'am, why it is so difficult, I will say my layman term if I don't understand. It is the cause eroded. Tibial tubercle become eroded. Traction. Okay. Bilaterally it could be or unilateral, mainly who are doing jumping, basketball players, sprinters, they are affected more. Okay. Osteochondritis dissections. Osteochondritis dissections, a pathologic lesion affecting articular cartilage of subchondral bone. So the subchondral bone will be the affected in osteochondritis dissections. Just remember, is osteochondritis knee joint are more affected, medial femoral condyle 70%. Pain activity already pain that is vague and poorly localized. So usually symptomatic leads to this joint, if untreated, dislocated. So just remember only one point for Osgood scatter disease. Traction and tibial tubercle will be affected. For the chondritis, knee joint will be affected, and it will be the medial femoral condyle. They will give this structure. Just remember, if it is untreated, the distal joint will be dislocated and it will be very painful if it is untreated. That's it. Shortcut scenario, and if most candidates face this exam question, we have to mark this way. Lateral epicondylitis and medial epicondylitis, golfer's elbow and tennis elbow. If you ask me this question, if anyone give any postgraduate exam taking preparation, this time it is very common question. Okay. Lateral epicondylis, medial epicondylis mainly is a medicine question, but they posted in the surgery cause why? Lateral epicondylis, remember, overuse injury involving eccentric overload at origin of common extensor tendon lead to tendinosis and inflammation at origin of this extracorporeal joint. So provocative test are the exacerbate pain. So if you do an provocative test, the pain will be the exacerbate, and lateral epicondyle resisted wrist extension and elbow will be fully extended. So just shortly, if you ask me, the tennis elbow is the overuse injury when elbow joint you use, it is exacerbated by lateral epicondyle resisted wrist. Okay. So if you do the question as a elbow fully when extended, when you extend fully elbow, that you will feel pain. Okay. Full extension of the elbow causing pain. Medial epicondylis golfer's elbow, overuse of the flexor pronator mass on it. Flexor pronate is a pronator mass, provocative test, pain with resisted forearm. Just they ask how in exam. I am marking that it is well. You can be identify markly. They ask this way. What they ask? First, if they ask medial epicondylitis, MOH exam candidates, if they ask medial epicondylitis, pain with resisted forearm, when you will resisted against forearm, pronator or wrist flexion, when you do wrist flexion, you will feel pain. It's the golfer's elbow. They ask this term and the diagnosis. Tennis elbow is that when you want to extend your elbow fully or wrist resisted. If you ask me, do you extend your wrist against my pressure? I want to extend my wrist and I'll feel pain. It's the tennis elbow, and they ask this way, and it is lateral epicondylitis. So see the scenario I'm giving, that it will be nice. So this is the elbow. When trying to extend, it is painful. It's a tennis elbow. Okay. This is the flexor. When try to pronate the forearm, it causes pain. It is lateral it's a medial epicondylitis or golfer's elbow. The pronation of the forearm or wrist flexion. Okay, this is the medial epicondylitis. Now fracture point. A fracture is a break in the continuity of a bone. Okay, with soft tissue injury, it may be complete or incomplete or open or closed fracture. What is the pace of bone healing? So see, In bone healing, the phase are the reactive phase. Means what? Initially, there will be the fracture, there is inflammation, followed by granulation for tissue forming. Reparative phase are the callus formation and lamellar bone deposition. Remodeling phase are the remodeling of the bone. That's it. Just remember the phase. Next question will be discussed with me, Dr. Saba Jisan. Dr. Saba Jisan is here.
Yes, ma'am. Assalamu alaikum.
Yeah.
A
Alaikum assalam.
34 years old man is uh, extricated from an automobile after a motor vehicle collision. The patient has an obvious deformity of his right thigh consistent with the femur fracture. Upon closer examination of right thigh, there is a bone visible through an open wound. He has palpable pulses and ankle brachial index is equal to 1. In addition to IV antibiotics, which of the following is the most appropriate management of his open femur fracture? Number A, observation. Number B, splint placement. Number C, external fixation. And number D, early irrigation and debridement. And number E is 4 compartment calf fasciotomies. Man, I exclude the option A and
Mm-hmm.
also option B because the
Yeah.
wound is open, and
Mm-hmm. Excellent.
external fixation is also excluded. There
Mm-hmm.
is option D and option E.
Mm-hmm.
So I prefer with the option D,
Excellent. Excellent done.
early irrigation and debridement,
And the brightment.
because
Cause.
yes,
Mm-hmm.
ma'am.
Mm-hmm.
Because the wound is open and it
Mm-hmm.
need irrigation and debridement
And fixation. And
because
then later fixation. Yeah.
and then later fixation because the patient have history of RTA. So
Excellent. Mm-hmm.
thank you.
So we have to manage this way. Excellent, Dr. Saba done that way. We have to remember. So see, there is a description. Type 1 on clean on less than 1 centimeter in diameter with simple fracture pattern. Type 1. Okay. Type 2 fracture is more than 1 centimeter, less than 10 centimeter without significant soft tissue crushing. Okay, fine. Third degree, third type is the open segmental fracture. Open segmental fracture, soft tissue injury more than 10 even MOH candidates. Even they ask the variety. Type 3 variety, just remember open fracture with soft tissue injury more than 10 centimeter. Type 3A fracture is the coverage fracture despite high energy trauma. If there is a high energy trauma, there is a type 3A. In type 3B, there is a periosteal strip inadequate soft tissue coverage, periosteal strip. In type 3C is open fracture that is associated with vascular injury. So type 3A, 3B, 3B from this, they were recalled from the image candidates. Remember this way, the 3A is the high energy trauma or extensive laceration, type 3B inadequate soft tissue cover with periosteal stripping, type 3C is open fracture associated with vascular injury. Same way, there is a chart. You can remember periosteum intake, adequate soft tissue coverage, vascular intake. You can remember this way. Now, open fracture. Doctors, remember, open fracture vascular assessment is very mandatory. Normal ratio, Dr. Saba's case was 1. So, normal ratio more than 0.9. So, we have to assess vascular insult. Any vascular trauma, brachial index we have to assess. So, acute brachial index will be the normally below 9. So, we have to start by antibiotic and we have to do 1 and 2. So, I already said type 1, type 2, mild form, cause there is a laceration, soft tissue injury. So first generation cephalosporin we can start. In third step, first generation cephalosporin along with aminoglycoside, firm injury or heavy contamination, we have to add penicillin. So type 1, 2, 3, a definitive treatment is urgent IV antibiotic, prophylaxis and incision and drainage. Type 3B, 3C and external fixator associated with urgent IV antibiotic and transtetanus prophylaxis and incision drainage. And remember, type 3B and 3C is the very life-threatening and complicated because there is an open fracture, heavy bleeding, heavy fracture associated with a heavy and highly injured, a high energetic fracture. Okay. So this question will be discussed with me. There's two questions. There's two questions just for discussion. Second question, this one will be discussed with me, Dr. Reza Orozi. Try to discuss with me. It's easy and DHA question.
Hi, ma'am.
Yes.
The 25-year-old male present to the emergency department after a low mower accident with traumatic loss of a high-grade toe. On examination, his wound is grossly contaminated with soil. In addition to a cephalosporin and an amyloglycosid penicillin is given. Which of the following is true with regards to the organism that penicillin is targeting in the injury? It is an anaerobic gram-positive road. It is an anaerobic gram-positive. It is an anaerobic gram-negative. It is catalase positive. It may be cause botulism. Antibiotic that administrated the antibiotic is cephalosporin, amyloglycosid, and penicillin. Then when we use penicillin, it must be gram positive, and it must be also gram positive road, gram positive coxi, gram positive coxi. It must be aerobic and gram positive road. Option A.
Actually, Dr. Reza, you tried your best, but thing is that you see, Dr. Reza, just
Yes.
if I say, Doctor, I am not medical student, I don't know anything, but I am injured, and you are seeing there is a lots of laceration, there is swelling in my clothes. So
Yes.
initially, after me resuscitation, a very important injection we have to give. What is that?
Cephalosporin.
No, it's antibiotic. I said emergency. I said I injured. Injection. We have to give.
Contamination. Yes. Must
So
we must
we have to
keep
give tetanus. We have to give.
immunoglobulin.
We have to give.
Immunoglobulin.
We have to give.
Immunoglobulin.
Yeah. We have to give tetanus toxide to prevent the botulism. To prevent the
Yes.
botulism. Okay. So
Yes.
what is the answer? So penicillin targeting injury. We are prescribing penicillin to cover us.
Yeah. To cover.
Cover us.
Yes.
Okay.
Totally.
Okay, so same way, first question, Dr. Reza, see, 4 days later, emergency come to your hospital with open fracture, signs syndrome with blue necrosis. What is the most common organism? Blue necrosis means already botulinum toxin developed. So it is the Clostridium botulinum.
Yes.
Clear?
Totally.
Clear?
Yeah.
Okay, thank you.
Yes. Thank you
Thank you,
very much.
doctor.
Welcome.
So the organism being covered with penicillin is Clostridium. Clostridium botulinum is gram-positive bacilli that is cause botulism. So Clostridium is a gram-positive obligate anaerobic spore-forming rod. So Clostridium is a obligate anaerobic spore-forming rod that is found in soil gut flora. So fragmentation or fermentation of glucose and may cause gangrene. Common bacteria are the Clostridium perfringens, most common Clostridium tetani, Clostridium Clostridium difficile, Clostridium botulinum. These are the most common organisms. So actually, if you ask me, I always think easy way. How? A patient come to my hospital, open fracture, I'll think regarding the botulism. I don't know Parfinji, I don't know regarding the Titani difficile, I don't know the botulinum, but I have to remember that I have to give a botus or tetanus toxin injection. So if this cover by antibiotic coverage, by injection coverage, tetanus toxin injection, I have to give the antibiotic to cover this Clostridium variety organism. I hope all clear, right? Any confusion from anyone? If any confusion, must ask me, because I will try my best to easily convey the message. Okay, so this question will be discussed with me, Dr. Hira Babar.
Assalamu alaikum, ma'am.
Walaikum salam.
After being injured by a bull in his mother's farm, a young man is placed in a cast for a supracondylar fracture of his humerus. A few hours later, he begins to experience intense pain, swelling, and weakness in the ipsilateral hand. Pulses are normal in bilateral upper extremities. Which of the following is the most appropriate initial management of this patient? Observation, repeat image of the humerus, elevation of the extremity, removal of the cast, for a forearm fasciotomy. After being injured by a bull in his mother's farm, a young man is placed in the cast for supracondylar fracture of humerus. A few hours later, he begins to experience intense pain, swelling, and weakness in the ipsilateral hand. Pulses are normal in bilateral upper extremities. Which of the following is the most observation, repeat image of humerus, elevation of the extremities, removal of the cast, forearm? Ma'am, removal of the cast is not an option. Forearm fasciotomy is not the option. Repeat
Okay,
imaging of the
okay,
humerus is not.
okay. I am telling you. Just 1 minute, Dr. Hira. Try. Say, see. Just think. I am stopping and I'm giving an instruction. Think. A patient is a mother's forearm injured. Okay. And you already given a cast, supracondylar
Yes, ma'am.
fracture, and you give a cast. So see, a patient come to your hospital, you already given cast due to injury. So whatever it is, but think in few hours later, complaining of intense pain, swelling, and weakness. These three words here. Just try to understand.
Yes, ma'am.
These
Yes, ma'am.
three words mean what? What is the diagnosis? Do you know? The diagnosis is, I'm telling, I'm instructing you, and you will be more confident. The diagnosis is compartment syndrome, which is life threatening. Cause when I given this cast, it morely injured the arm, the vessel caused impaired, and swelling started, pain started. I have to immediately, what is
Remove
the
the
answer? I
cast.
have to immediately remove the cast.
Remove the cast.
Understand the question?
Yes, ma'am.
Clear?
Yes, ma'am.
Clear?
Yes,
The
ma'am.
why
Yes, ma'am. Yes, ma'am.
this only three words: intense pain, swelling, weakness. I have to remove cast immediately, because I don't want to see there's a person normal bilateral upper extremity, so I don't want to injure any nerve compression, so I have to remove the cast immediately. Clear?
Yes, ma'am. Yes, ma'am. Clear.
Okay. So
Thank you so
now
much,
I
ma'am.
feel you are clear. I think you are
Yes, ma'am.
clear,
Clear.
right?
Yes, ma'am. Clear. Thank you so much, ma'am.
Okay. So I say, though it's not very easy to perform today's session because orthopedics is really tough, but the thing we have to try. That's it. Okay. So for this question, you first see, I will ask the question. First see the image, unstable case, and whose candidates will perform this case. Read the sign and scenario and associated with this image and perform gradually. Okay. This question will be performed by Dr. Nandini Sharma.
Good evening, ma'am.
Good evening.
24 years old male presented following a motorcycle crash with isolated injury to right lower extremity. He has a 3 into 2 centimeter wound over the fracture site, and he immediately receives a gram positive and a gram negative coverage along with a tetanus booster. The patient is splintered, optimized, and brought to operating room where the wound is debrided and classified as type 3B fracture. Deemed stable, the plastic surgery team arrives and acutely performs a free flap of a coverage for a coverage following definite fixation with the intramedullary nail. All of the following factors that has been shown to increase the infection sites, except time to antibiotic
Except.
administration.
So your question is all are right except we can't do there in this situation we can't do one option that is wrong we can't do all are right but one option we can't do right Dr. Nandini. So you
Yes, ma'am.
already read the scenario and already you have to read the option. So you have to think this patient come to my hospital. I will do all, but except one option I will not do. Which is that?
Uh,
So read the
time
options.
time
A, B.
to
Yeah. Okay.
a time
Mhm.
to initial debridement.
No, you read the option again. Read the option. One,
Okay.
two, three, four. Mhm.
Time time to antibiotic administration. We will be doing that, ma'am. Thoughtfulness of debridement.
Okay.
We will
Okay.
do that.
Mhm.
Uh, time to initial debridement.
Yeah.
Ability to close, cover, and open wound. Time to definitive fixation.
So
Ma'am, I guess
doctor,
it's
yeah.
ability ability to
Mhm.
close, cover, and open wound.
Okay, so see, I'm telling you, I'm giving instruction. This scenario, you see, there is a motorcycle crash injury, isolated injury in the right lower extremity. After the accident, before initiating antibiotic, we have to first give prophylaxis to prevent the contamination. Then we have to we have to give the antibiotic. So A and option A option is correct. It's accepted. Accepted. Okay. Throughness of
Yes, ma'am.
debridement means we have to debride the contaminated area. So throughness of the debridement also accepted. Time of initial
Mm.
debridement. Yes, we will take the time for debridement. Yes, we have to take time to which are the site we have to do debridement. It is also accepted. Ability to ability to close and open on time to definitive fixation. So see, your answer will be either D or E. So from the
Yes,
D
ma'am.
and E, so see, it's the unstable case. It's the unstable case, but initially we'll try to cover the open on. We'll try ability if there's an
Oh,
ability, if there's any hint. So it will try first, right? An open on fracture or
okay,
closed
ma'am.
on fracture, we have to. So it is also accepted. So, but definitive fixation is not possible except tertiary center or except a consultant level for definitive fixation, right?
Oh,
So what is not the
okay, okay,
accepted?
ma'am.
Clear?
Time to definitive fixation. Yes, ma'am.
Yeah,
Understood.
clear. Okay, thank you, doctor. Thank you.
Thank you, ma'am. Thank you, ma'am.
Yeah, okay. So compartment syndrome already discussed, Dr. Hira. So devastating condition where an osseofacial compartment pressure rises. So compartment you given a cast but compartment pressure rises. It's a very harmful for the patient, which causes decreased perfusion means oxygen are not supplying, may load irreversible muscle and nerve damage, very harmful. Cascade of events includes cascades of even local trauma, soft tissue destruction. So these cascades involve soft tissue destruction, bleeding and edema. So bleeding and edema associated with increased interstitial pressure, vascular occlusion, and myoneural ischemia. So already started ischemia because there is a no oxygenation started because there is a compartment pressure rises. So passive stress is the most sensitive finding prior to onset of the ischemia. So we have to give a passive stage. So diagnosis is clinical presentation consistent with compartment. So this Dr. Hira case only clinical presentation. Only there's a pain already swelling started after giving the cast. It's a clinical. If I'm doctor, clinically by listening the symptoms, I have to diagnose the compartment syndrome. Immediately, you have to remove the cause. Compartment pressure more than within 30 milliliter of diastolic blood pressure and absolute intercompartment in absolute intercompartment value greater than 30 to 45 millimeter to make the diagnosis. Actually, in DHA, they ask directly the compartment pressure for the diagnosis of the compartment syndrome or other way doctor sorry MS candidates they give this value this scenario. Okay, So this question will be discussed with me. Dr. Kishori is here or not?
I'm here, ma'am.
Yeah. Question 7.
A 6-year-old boy with progressive bilateral genivarum undergoes the surgeries shown in figure A. Ma'am, why it's so tiny, ma'am? Can you little
Okay,
bit zoom
tiny.
it, ma'am?
It's the okay. It's so tiny, right? Is that
Okay,
clear?
okay, ma'am. On
I don't know if
post-operative
what. Mhm.
on post-operative rounds later the day, the patient appears sedated after several doses of pain medication. His toes are pink with bricks capillary refill. However, passive motion of his toes causes pain. Among the answer choices listed, what is the best management strategy for this child? A child is 6-year-old. Okay. Elevate his leg and re-evaluate on morning rounds. Adjust his pain medication to accommodate for his increasing pain. Administer a muscles relaxant for leg spasm. Cast removal and measurement of compartment pressure with a standard device. Examine the cast for areas of constriction and re-evaluate in the morning. Okay, a boy is 6 years old and bilateral genivarum. He underwent surgeries and after post-operative, after post-operative,
Round.
the
Round. After round.
post-operative after round, the patient appears sedated. He appears sedated with several doses of pain medication, and his toes are pink with bricks capillary refill. However, passive motion to his toes causes pain. Even though he's sedated, but the passive motion of his toes causes pain.
Yeah.
The,
You are right.
among the answer choices listed, what is the best management strategy for this child? After sedation, also there is pain. Elevate his leg and re-evaluate on morning rounds. Adjust his pain medication to accommodate for his increasing pain. Administer muscle relaxation for leg spasm, cast removal, and measurement compartment pressure with standard. Ma'am, is it D?
It's a D. Excellent. Excellent. Though it's so tiny, but you done excellent. It's a D because already we given pain medication, though there's still persistent pain. So compartment pressure we have to do analysis, right?
Yes, ma'am.
Excellent done. Thank you, doctor.
Thank you.
So this question will be performed by Dr. Mousumi. If Dr. Mousumi is not here, Dr. Badhun.
Yes, ma'am. Good evening.
Good evening.
A 28 years old male sustains a mid-shaft fibula fracture after being kicked during a karate tournament and develops compartment syndrome, isolated to the lateral compartment of his leg. If left untreated, which of the following sensory or motor deficit would be expected? Decreased sensation on the dorsum of his foot involving the hallux, third and fourth toes, plus foot eversion, inability to plantar flex the ankle, decreased sensation of the dorsum of his foot involving the first web space, inability to dorsiflex the ankle, and inability to abduct his toes.
So,
Fibula fracture, mid-shaft fibula fracture, and compartment syndrome already developed. The lateral compartment, okay. In through the lateral compartment, nerve goes to common peroneal nerve.
Yeah, common peroneal. So,
And common peroneal nerve, then supply of the foot will be lost. Then decreased sensation of the dorsum of his foot involving hallux, third, fourth toes. Third, fourth. Okay. Inability to plantar flex the ankle. Decreased sensation on the dorsum of his foot involving the first web space. Inability to dorsiflex. Inability to dorsiflex the ankle. It will be the answer.
So you are analyzing your question very nicely, but the thing is that the anatomy, that common peroneal nerve in the third and fourth toes. Okay, this is the anatomy.
Okay.
Actually, anatomical knowledge really we are very poor. It is really accepted. So answer is the what? Third, fourth
Decrease
toe supplied
sensation of
by
the
decreased sensation. Excellent. Okay, this is the paid question. Is remember the anatomy, common peroneal nerve supply. Even there is a mark common peroneal nerve, or they said common peroneal nerve injured, or they said lateral side of the thigh injured. So remember lateral compartment syndrome, lateral side of the thigh associated with common peroneal nerve, which decreased sensation over the third and fourth toes.
third, fourth,
Okay.
and fifth. Okay, ma'am. Thank you, ma'am.
So this question I already discussed regarding the compartment pressure. It is not in the theoretical part. Just you can see after my session. First question will be discussed with me, Dr. Moshumi. I see she is on platform, but before that she was not. So Dr. Moshumi, if you are here, you can able to talk with me. Okay, I feel she is not here, right? But I'm seeing she already unmuted the mic. Somehow she's facing difficulty. So first and second question. First question, Dr. Rehana is here.
Yes, ma'am.
Yeah. First question.
Patient came after limb trauma with severe pain and paresthesia between his toes, and it was pale. X-ray shows fractures. Intracompartmental pressure was 35. What to do? Internal fixation, close reduction, external fixation, external fixation with fasciotomy. So the patient has limb trauma with severe pain and paresthesia between his toes and pale. So
So
mm,
see,
sin,
intercompartmental pressure is 35. So it means it is
uh, it is compartment syndrome, more than
okay.
40, more than
So
30.
yeah, more than 35 or more than 30, whatever you say. So see, in this case, what you will do? Compartment pressure already started. What you will do?
External fixation with fasciotomy.
Yeah, its answer is external fixation with forward fasciotomy. Thank you, doctor.
Thank you.
First question, first one, very important question. First question will be discussed with me, Dr. Monia Jaman is here. It's a DHA question. Try to
Just now I joined.
discuss.
Assalamu alaikum, Dr. Irin.
Alaikum
Just now I
salam.
joined.
Yeah.
I don't know what you have
No
put
issues.
today. Too much
No
patient.
issue. No issue.
Just
Just
now I joined.
yeah.
Okay,
Yeah.
I
No
will
issue.
read it.
Yeah.
I don't know
Just
what
like
happened.
yeah. No issue.
Crash injury to his feet. After
Yeah.
stabilization, the patient on examination cold and decreased pulse in the affected foot. What is the best next step you will do? Pulse is decreased. So if pulse is
Yeah. Pulse is
decreased,
decreased.
yeah, intake pulse, it is Doppler, and absent pulse, it is CT angio. So decrease.
But they ask best next means you what you will do right
Best
now.
next.
Best next not
CT,
yeah.
CT,
Best next.
CT angio. CT angio.
CT angio always best definitive or best. It's not best next,
Okay, okay.
not next. It's a next. Okay. So best next will be. So best next, or if I ask you what is the next step? If I ask Apu what is the next step?
Injury to the feet. Compartment compression.
No. So see, there is already you done nicely. The CT angiogram we have to do actually is a definitive test I will do, but the see decreased pulse, right? Decreased pulse. So I have to assess by duplex ultrasound.
Ultrasound.
Okay. Duplex ultrasound. So I am clearing. This is the exam question, DHA question. Just remember, best next initially or next, this means ultrasonography, Doppler ultrasonography. If there's what is the best definitive or appropriate next, or it is the best definitive or specific, so it will be the CT angiography. Okay, this way they ask. Clear?
Okay, okay.
Okay, okay, thank you.
Thank you, thank you.
So what are the early thank you. So these are the what are the early complication of the fracture? Just we have to remember the shortly. It's a not so exam question, but exam they ask from the fat embolism systemic. If any fracture occur, the fat embolism very common. So though they just one point we have to remember eosinophilia. This goes towards the fat embolism. Thromboembolism, exacerbation, underlying disease, diabetes, ischemia. These are the complication of the fracture. Local, it could be systemic, locally nerve damage, any hemarthrosis, compartment syndrome, own infection, it could be acceptable. So this question will be discussed with me, Dr. Maha Umer.
Yes, ma'am.
Yeah.
A 20-year-old male sustained bilateral humeral shaft fracture and bilateral femoral shaft fracture from a motor vehicle collision. While awaiting surgery, the patient suddenly becomes tachycardia, hypoxemic, and experiences mental status changes. Physical exam demonstrate multiple petechiae in his bilateral axilla. CT angiography is ordered and is negative for pulmonary embolus, but is the most likely diagnosis. Hypovolemic shock, stroke, fat embolism syndrome, necrotic overdose. It's C, fat embolism syndrome. Because
What is the
humerus,
clue? Yeah. Tell
a
me.
humeral
Explain.
shaft fracture and femoral shaft fracture. And then this point goes toward the fat embolism syndrome. Patient
Yeah,
suddenly
yeah.
tachycardic and hypoxemic and
Excellent.
experience mental change.
Yeah, excellent done. Dr. Maha Umar, your performance really excellent. So you have to think regarding the fat embolism. Though there is no eosinophilia count, there is this explanation like that. There's a bilateral humeral shaft fracture and there's a femoral shaft fracture associated with motor vehicle collision. There's a hypoxia experience mental status changes. So it's embolic status. It's the fat embolism. This question already marked, just remember, just for discussion, this already marked was why isolated fractured tibia. Just remember, isolated fractured tibia after being hit on leg with a car. Okay. Radiograph of the leg showed tibia shaft fracture. Okay. An expected outcome of surgical fixation with intermediate nail as compared to close reduction and application of the long leg cast. So, which of the following? So, C is a hit by the leg by a car with isolated tibia fracture. So, following there is a delayed weight bearing, increased malunion, decreased edema. So, see, after a tibia fracture, outcome of the fracture injury in the treatment always depend how I am doing fixation, how I am doing nailing, how I am doing close reduction. This all depend your performance. So improve alignment. If you give strong alignment, strong you are the skill, it will improve your function of the fracture. So there are explanation that plate nail cast, intermediate nailing, operation of choice. So all surgical fixation, all alignment is very important clue for improve the functional status. Okay. Second question, say pediatric tibia shaft fracture pattern. Incomplete, it could be complete, it could be tibial spiral fracture. So incomplete green stick fracture, they ask directly green stick fracture incomplete. We have to give long leg casting. Just remember two ways, they ask either they ask incomplete fracture or they ask tibia fracture. So we have to give long leg casting cast. Complete fracture means tibia with or without ipsilateral fibular fracture. So you have to do close reduction and long leg casting. If no reduced, so you have to do surgery. This they ask from the management by this way: complete fracture or incomplete fracture. Tibial spiral fracture, we have to give long leg casting. So this question for discussion. First question, second question will be discussed with me, Dr. Madhiya Bhatt. Second question.
Yes, ma'am.
Yeah.
A patient fallen down from 3-meter height. He felt severe pain and swelling of the lower right leg. X-ray showed comminuted fracture of the lower tibia. What is the most accurate management? Ma'am, open reduction, internal fixation, and elevation.
So see, you are a doctor in emergency. A patient come to hospital that this patient fall down from 3-meter height. Severe pain, swelling. Okay, and right leg.
In
X-ray
fact, it's
showed
a closed.
comminuted fracture. So
Yes,
comminuted
so it
fracture
would be
means
closed reduction,
no,
cast,
no.
and elevation.
Comminuted fracture with lower tibia. What is most? So comminuted fracture, you can't do closed reduction. You can't do internal fixation first. We have to do first external fixate.
External
Okay,
fixation.
because it's a comminuted fracture. Okay, so this way they ask in the exam question. Just remember, comminuted fracture means I have to do externally fixation first. Okay.
Okay.
Okay, there's a three question. There is in this scenario. There's a three question. Three question is very important. I want to not perform by my candidates. I want to do and to discuss by what they ask. Fracture of femur and angulation in 6-year-old. What is the management? So fracture of femur and angulation. There is a picture. You see, less than 6 year, always conservative management. Spica we have to give spica. But if it is 6-year old, but there's a femur fracture with angulation, so we have to do close reduction with spica. But before 6 year, only spica. After 6 year or equal to only 6 year, we have to do close reduction and spica. Answer is C. Okay. Second question, my mid-shaft femoral fracture, 30-degree angulation, child 4-year with management. Okay, so child 4-year, there is a option or if open reduction, internal fixation, or if with internal medullary nail and traction. So it's a mid-shaft femoral fracture, or it's a mid-shaft. So and there's a 30-degree angulation. Doctor, this question who can answer? What will be the answer? Mid-shaft fracture with 30-degree angulation?
Ma'am, traction.
No. It's not traction because 30-degree angulation. Its angulation is huge. We have to do fixation by intermedullary nail. Okay. We have to do fixation by intermedullary nail. Answer is ORIF with intermedullary nail. So third question is that 6-year patient with mid-shaft fracture or mid-femoral fracture, 30% anterior angulation. What is the management? So same way, only 6 year, always I say, just correlate the option with scenario. I said below 6 year only spica, after 6 year or equal to 6 year with spica close reduction. So see, there's a mid-shaft fracture 4 year. We can't do traction. We have to do internal fixation by intermedullary nail. There is no spica. There is no observation. There is nothing. Either you have to do intermedullary nail or only internal fixation by ORIF. So third question, shaft femoral fracture, 30% anterior angulation, 30% or 30-degree anterior angulation. Who can answer? Try to understand. Who can answer? Now, main fact is the patient is 6, so equal to 6. I already discussed. What is the answer? Anyone?
This OR and
Option D, ma'am.
B. Is the answer B? Who is answering?
D, Dr. Munia.
Dr. Monia. Excellent. Excellent. B is the answer. Close reduction with hip spica cast. So 6 year, 30-degree angulation. You have to give spica cast with close reduction already. Now, excellent, done, Apu. You nicely listening that we have to do close reduction with hip spica cast. Thank you. So next question, important question. Already I discussed this question by previous way. So no need to discuss. Just shortly remember this kind of fracture. See the fracture review. So this kind of fracture is that emergency department, you are emergency doctor and being struck by a car, he was found to have injury in the fracture. There's a humerus fracture, mid humerus fracture. Okay. So we have to give what? Anyone? 8 years. We have to give fixation with flat and screw. Like there's no hip spike because it's only mid shaft humerus, not femur. So we have to give orif with flat and you have to do a screw. But if less than 6 year, spica casting. Okay, this way you have to remember. So this femoral shaft fracture pediatric treatment, remember, below 6 months, any fracture pattern below 6 months, pelvic harness or early spica casting. In exam, they ask early spica casting in the option. 6 months to 5 years, stable fracture pattern, early spica casting, poly or trauma or multiple open fracture, external fixator, 5 to 11 year, if below 49 kg, so it's a flexible lens. If it is length unstable fracture, it's a orif with submuscular bridge. And if more than 11 year, it's the patient weight more than 49 kg, we have to give intermedullary nail fixation. Just shortly remember this chart enough for the marking the question in the exam. This is a little bit huge description just for before that starting this question. Supracondylar fracture, this is type 1A, 2A, 2B and 3. So type 1 means non-displaced. So see, non-displaced. Type 2A means intact posterior cortex. So posterior cortex intact by hinge in extension. So see, hinge is extended. Type 2. Okay. No rotation or translation, but the type 2B is hinge in extension but rotation with displacement. Already this will be the displaced, this picture. Okay. If there is a no rotation, it's type A. If there is a rotation, it's a type 2B. 3 is complete displacement. See, there's a complete displacement is the 3. So supracondylar fracture. So see, a supracondylar fracture patient. So see, they are said just for discussion. No need to be worried. Dr. Priscilla Pushpam.
Yes, ma'am.
Yeah. Try to
7,
discuss.
okay. 7-year girl present to the emergency room after a fall with right arm pain. She has full motor and sensory function. Her fingers are warm and pink with capillary refill less than 3 seconds. And she is noted to have ecchymosis in her antecubital fold. What is the management? Close reduction, long arm casting, discharge home. Close reduction, long arm casting, admission for 24 hours. Close reduction, percutaneous pin fixation, discharge home. Close reduction, percutaneous pin fixation, admission for arteriography. Open reduction with brachial artery exploration and admission for observation. Because she has full motor and sensory function, warm and pink, no need to admit. So, so if B answer cancel because no need observation. E answer cancel because there's no artery. They never say artery is involved. A, B, C, D cancel because no need for admission. Either A or C.
Excellent. What is the answer? Either A or C. Excellent, done. If you do wrong, it is acceptable. You got the mark because you nicely excluded other option.
Yeah.
So your patient emerged the room with right arm pain and there is a capillary refill below 3 seconds. She is noted ecchymosis. So we have to do
pin fixation.
Pin fixation. Pin fixation and discharge home.
Discharge home.
Okay. Pin fixation and discharge home. Excellent. So this way you have to understand nicely done. Supracondylar fracture as one of the most common children fracture is a 95 to 90% extensive type. So anterior interosseous nerve or neuropraxia is the most common nerve causing anterior interosseous nerve. Access vascular perfusion, well perfused, warm and pink, poorly perfused, cold, pale arterial capillary refill more than 2 seconds, long arm casting, warm perfused hand without neurodeficit type 1. So close reduction. So see, when we will do long arm casting, if warm perfused hand and there is a no neurological deficit, but closed reduction percutaneous spinning like this case type 2, type 3 supracondylar fracture and fixation type. Non-urgent can we will overnight wait warm perfused without any neurological deficit, so we can do wait. Urgent same day overnight. So paralysis, if there is a paralysis, well, so vascular injury, clotting elbow, we have to do urgent emergency. We have to do nailing. Okay, same day. Emergency within hour we have to take decision if it is fully perfused, pulseless, check vasculature. So if well perfused, admit and observe for 48 hours. If it is not, so you have to do perform vascular exploration and close reduction. Okay, so I hope this point, the management point, will be beneficial for all. Just to remember this question, same question, Dr. Is Dr. Sasma after SMLE question, SMLE exam. So and same this ma'am, the same picture I face in the exam. So I want to discuss if Dr. Moshumi is here, if want to talk with me, or she is facing difficulty to discuss. Okay, Dr. Moshumi is not able to talk. Just for discussion, this is the exam question. So the recent exam question, Dr. It's a Shamim Shahid. It's a Mehis, right? It's a Mehis. First question, this question. Hmm? Mehis is here?
Yes, ma'am. Yes, ma'am.
Hmm.
A 72-year-old woman falls onto her left hip after tripping over a curb during her daily 3-mile walk. An injury radiograph is shown in the figure A. What is the best long-term solution? So, ma'am, option C is ruled out because she is active. ME arthroplasty, not active. She is active. Cannulated screws. She is less than 50. The A is also ruled out. So B and C, best long-term solution. Total.
So it's a 72 and already fall down. Okay, so this 72-year-old. So what we have to do? Best long-term solution is the total.
Total hip
Yeah,
arthroplasty.
yeah, it's a total hip arthroplasty. So if it is active, we can do the hemiarthroplasty. If not active, we can do hemiarthroplasty. If less than 50 year, we can do cannulated screw. So femoral neck fracture observation alone, if there is a high, no ambulatory or no high risk of surgery, we can do observation. Or if by cannulated screw fixation, if patient below 50 years. Okay, hemiarthroplasty if there is a debilitated elderly patient. Total hip replacement. Just read this question, this pattern. Older active patient or persistent osteoarthritis, we have to do total hemiarthroplasty. This is very important exam question. This question will be performed by Dr. Hura.
Yes, ma'am. A 12 years old boy is brought into emergency room by his mother for, for walking with a limp for several weeks, which become worse following physical activity. On examination, his heart rate is 75 beats per minute. Blood pressure is 110 by 80 and respiratory rate is 14 beats per minute. His BMI is 24.3 kg per He has tenderness over his right thigh and limited internal rotation. Which of the following is the most likely diagnosis? Slipped capital femoral epiphysis, like Kauf's disease, dysplasia of the hip, Talpes equinovirus, and by blot disease, John's disease, by limping. 75 low BMI is fine. Slipped capital. Ma'am, it's like Pathy's disease because it's
No.
limping
Mhm.
and it's a
Doctor,
BMI is
yeah, is
BMI
okay.
and age.
So, so see, sir, emergency room patient walking with a limb several weeks, okay, or
Yes, ma'am.
following physical activity. So see the picture, see the patient, the baby, a 12 years boy. So question or following physical activity. So trying to play the ball, and when physical activity. On examination, heart rate okay, blood pressure 110/85. The thing is that BMI also okay. So tenderness over his right thigh and limited internal rotation tenderness. Okay, so what is the answer? Internal rotation. It's
Slip,
not
slip,
slip.
slipped capital
Yeah.
femoral
Yeah, it's a split capital. There's a difference, very important. Thank you, doctor. Very important that we have to know. We have to know. Regarding the question, we have to know that split capital capital femoral epiphysis is a painful age around 10 to 16 years. It's endocrine associated with endocrine disorder, obligatory external, just in exam 1 point. Internal rotation painful with activity. It is the point. For leg cuff prosthesis, loss of internal rotation, abduction. But for slipped capital femoral epiphysis, obligatory external rotation during passive flexion of the hip. So, Dr. Hira's case, how we can differentiate? Tenderness over his right thigh and limited means can't rotate, limited means can rotate but there's pain, limited internal rotation, that doesn't mean loss of internal rotation. So when loss of internal rotation can't move, limited means she can move but painful, it's a limited, but when loss it is leg, cuff, this. So DDH is a painless is a muscular torticollis and metastasis and adductors. So remember, for this dysplasia of the hip, this DDH, just remember dysplasia of the hip is associated with muscular torticollis and adductors. 1 point, just remember, it is not so important. Exam point, this is cap femoral epiphysis, slip capital femoral epiphysis, and leg curve persistence. These are the important. Another, this disc deep hyperplasia or dysplasia of the hip, it is not so important. Shortly, we have to remember it's a painless. Both are painful. This slipped capital femoral epiphysis and leg curve persistence all are painful, but this hip dysplasia is not painful. Another point is that these are the positive if below 3 months and limitation if it is abduction more than 3 months. That's it. See, there's a picture. Actually, this picture for the heart candidate is very important. This picture also face Dr. Sachma. This same picture, she was telling, ma'am, same picture given in my exam. Slip capital epiphysis, same picture. Just posted me the recall. First is just remember three scenario for the exam. Okay. So valgus and varus type, you see genu valgum, knock-knee, and genu varum, block neck. Exam question, medicine question, this question we can discuss by Dr. Fatima is here to talk. Okay. So, Doctor, I can start from the Dr. Saba. Dr. Saba, discuss this question. Okay, maybe she's not right now. So, Dr. Ikra, nice
Yes,
question example. Yeah.
a 65 years old man presents with acute onset of pain and swelling erythema of the left knee. He denies previous episodes or trauma of the knee. The differential diagnosis include septic arthritis and gout. Which of the following is the best study to differentiate between gout and septic arthritis? White blood cell count, X-ray of the knee, MRI, bone scan, evaluation of the synovial fluid aspirate. Ma'am, I think it's last option, evaluation of synovial fluid aspirate.
Yes, its answer is last option, evaluation of the aspect of the septic arthritis. Thank you, doctor.
Yes.
So this way you have to understand the question pattern. Radial nerve important. Radial nerve syndrome. This is the compressive syndrome. Thank you, Dr. Zikra. Radial tunnel syndrome. Remember, radial nerve injury by pain only tendons 3 to 5 centimeters distal to lateral condyle. So mechanism is activity modification temporarily. We can give initially NSS, but Wartenberg syndrome is a compression of the neuropathy. For a radial nerve injury, shortly remember radial tunnel syndrome and the compression syndrome. That's it. This is Dr. Kishore is here.
I'm here, ma'am.
Yeah.
A 45-year-old woman is seen with wasting of the intrinsic muscles of the hand, weakness, and pain in the wrist. Which of the following nerves has the most likely been injured? Ulnar nerve, radial nerve, brachial nerve, axillary nerve, median nerve. Ma'am, it's the radial nerve.
No, unfortunately, it's not radial nerve. So see, why not? First of all, wasting of intrinsic muscle of the hand. Okay, weakness and pain in the wrist or full wrist. Okay. So see, if I ask which of the little finger supplied by radial or ulnar?
Ulnar
Little
nerve, ma'am.
finger,
It's the answer.
ulnar nerve.
Answer.
So,
Yes.
yes, so answer is A. Because why?
Ma'am, answer.
Compressive neuropathy of the, yeah, tell me.
Yeah, ma'am, you can go. Ulnar
Okay,
nerve
so,
is the answer.
yeah, compressive neuropathy of the ulnar nerve cause lever of the wrist. It's a cause Guyon's canal, most commonly injured by ganglion cells. So, see, your question, direct question, your direct question is that intrinsic muscle of the hand along with pain in the wrist. Pain in the wrist is the ulnar nerve. Radial tunnel syndrome, Dr. Kishori, if I discuss before that, radial tunnel syndrome. So there, see, radial tunnel syndrome, I'm again opening that chart. In radial tunnel syndrome, there is no associated with wrist pain. So see, radial tunnel syndrome, compressive neuropathy, level of proximal forearm, is Watermark syndrome, compressive neuropathy associated with paresthesia. This compression syndrome, neuropathy associated with supply the forearm. So associate radial nerve associated with forearm. So ulnar nerve associated with intrinsic muscle of the wrist. Okay, shortly I have to remember.
Okay,
Okay,
ma'am.
so we have to remember the
Yes, ma'am.
splitting and surgical decompression management. Okay.
Mm-hmm.
Another way,
Yes, ma'am.
diagnosis is paresthesia small and intrinsic muscle weakness. Intestinal sign. Intrinsic muscle weakness is the ulnar nerve supplied and cubital tunnel syndrome along with this intrinsic muscle weakness. So there is a chart. Thank you, Dr. Kishori. So there is a chart, peroneal nerve, tibial nerve, radial nerve, all will be remember this chart. I said if anyone try to obscure for exam preparation, orthopedics is no need. If anyone try to understand, it's okay because orthopedics I taken this session at the last moment because it's if anyone want to take the preparation can take no issue because ulnar nerve, radial nerve injury can be mismatched, no issue. So carpal tunnel syndrome, last question. So there is a musculocutaneous nerve, axillary nerve, radial nerve, medial nerve, ulnar nerve, the combination, the fracture, injury type, management, all deformity. There is a C radial, there's a wrist or ulnar, there's a toe hand, there's a app hand deformity. So see the hand of the, and there's a ulnar nerve, claw hand. So wrist drop, hand of the benediction is the median, and ulnar nerve is the claw hand deformity. The same way, this picture is a very important. Median, radial, ulnar, and anterior interossseous nerve. Anyone can understand, and just remember the assessment: motor flexion, finger flexion by median, extension of wrist, medial mediocarpal joint extension. Okay, so carpal joint or carpophalangeal joint, this extension disability associated with radial nerve, and ulnar nerve associated with finger abduction and adduction. This is the ulnar abduction and adduction. Anterior interossseous associated with interphalangeal joint flexion and induction. Okay, these are the charts. All can remember this chart. It's easy. If they give any chart or image, we can answer nicely. Easy question and 3 questions I'll discuss. 3 questions very important. First question will be discussed with me, Dr. It's Reza, Dr. Reza Uruzi.
Yes, ma'am. An 8-year-old girl comes to the office with increasing tight pain, mostly at night. A radiograph in figure. The patient's YPC and ESR are both elevated. What is the most likely diagnosis? ESR is high, YPC also high, and in the increasing tight pain, mostly at night. And in radiograph also, in the options, osteosarcoma, osteomyelitis, chondrosarcoma, and Ewing sarcoma. In 8 year, there are I think there are expansion of muscle in the graph.
Okay. Dr. Reza, see there's the X-ray and they said onion skin appearance. Okay, so this onion is
yes. Ewing sarcoma has this. Yes, this.
Yeah, its answer is the Ewing. So yes, thank you, Dr.
Thank you
Reza.
very much.
Second question will be the discuss with me, Doctor. It's a Dr. Anjana.
A 24-year-old man twists his knee in a softball accident. He denies any preceding complaints and is very active and healthy. These findings are most consistent with what diagnosis? Periosteal osteosarcoma, osteochondroma, Ewing sarcoma, or chondrosarcoma. Sunburst appearance. And periosteal osteosarcoma.
Excellent done. Thank you. Why? Cause 24 year and twist his knee. There is a sunburst onion skin. The sunburst onion skin picture only for the periosteal osteosarcoma. Thank you, doctor. So there is osteoma. There is a difference. So this is sunburst appearance. So see osteoma, and there is a periosteal osteosarcoma. So see. Osteoma associated with age 5 to 25 years and usually found within the bone cortex and is associated with, we have to give the NSAID first, percutaneous radiofrequency ablation or surgical resection with curettage. Periosteal osteosarcoma, see, Dr. Anjana's case is the femur and tibia most common site, usually occur 15 to 25 years age. We have to give multi-agent chemotherapy and limb salvage resection. So the periosteal osteosarcoma associated with in the female age group 30 is the parosteal, not peri is a paro, so it's associated with metaphysis of long bone most common site. So wide local surgical excision is the management plan. Chondrosarcoma is the older age, like 40 to 75 years, associated with pelvis, femur. So you have to do wide surgical resection. Okay. There is aneurysm. Okay, so just remember we have to do non-operative fracture management will be the ABC associated with fracture, acute fracture until has healed. So once healed, we have to give aggressive curettage, adjuvant therapy and grafting. So Jung sarcoma already I discussed with Reja's question. This is distinct small round cell. Age is younger as a child. Children is 5 to 25 years. Genetic T1 1122, large destructive lesion, periosteal reaction may given onion skin appearance, Dr. Reja's case, and we have to give chemotherapy, linked slab cell, and adjuvant radiation. So there is a benign and malignant differential point. Just remember this chart. Osteosarcoma malignant variety, osteoma is a benign variety. So now vascular surgery. Vascular surgery question very high topics for the exam regarding the acute limb ischemia, chronic limb ischemia, many candidates facing many difficulties. Shortly I'll discuss. Peripheral arterial disease C, narrowing of the distal arteries most commonly due to atherosclerosis. Presentation will be the intermittent claudication, weak or absent pulse, skin and hair changes, ulceration. It is the peripheral, so see there's a narrowing of the vessel. Narrowing of the vessel is the peripheral arterial disease. Investigation initially your first line Doppler ultrasound, Dr. Monia's case Doppler ultrasound we will do CT or MRA if we have to consider intervention or specific definitive investigation. Management first initially we advise, but a patient with severe limb pain, if I suggest quit smoke, is it valid? No. First, after discharging or advice is the quit smoking, lifestyle modification, supervised exercise. These are the advice. Many can ask me, madam, why supervised exercise? Ask or read the scenario. What they ask? Is it discharge time? If acute setting, what will be the answer? Acute setting never supervised exercise program, or your patient come to your hospital or GP clinic and if there's a pain, you have to start the low molecular heparin or heparin medication. If you start supervised program in acute setting, it will be the harmful for the patient. So treatment hypertension, start statin, irreversible lifestyle modification, antiplatelet clopidogrel, and we have to give oxalate native Nephidofluoride, oxalate or exercise has failed. We have to do angioplasty stenting or bypass surgery. These are the definitive. My dear candidates, don't do wrong. Initially, the investigation, initially management, acute setting or chronic setting. Chronic setting means patient telling, ma'am, I can't work, I have pain in my limb. After doing work, I have to take the rest. So it's a chronic case. So you have to start the supervised exercise program. We have to start the lifestyle modification. We have to start the antiplatelet drug. So it is not acute setting. So you have to understand what is the acute, what is the chronic setting. How I can manage this patient in the GP clinic, how I can manage this patient in hospitalized. So say in peripheral arterial disease patient claudication pain and what symptoms correspond aortoiliac occlusion associated with pain in the buttocks, erectile dysfunction. If it is femoral artery, pain in below the inguinal ligament and femoral popliteal occlusion, pain in below the knee joint. So the presentation and discussion, I'll discuss first clinical presentation. Asymptomatic, intermittent claudication, onset of slower limb pain with exertion, typically localized to cuff muscles. Second, critical, chronic rest pain more than 2 weeks, there's a necrosis gangrene. So clinical presentation must remember. So first question will be discussed with me, Dr. Hira.
Yes, ma'am. Question.
Okay. Question
Many
is there.
question. Many
First,
question.
no. Your question is here actually. The
But
question was previously.
okay.
I'll discuss the explanation later.
Okay, ma'am. A 62 years old man, a known diabetic and hypertensive, presents with 4-hour history of sudden left leg pain. He had a history of left leg pain after walking 200 meters that make him stop and is relieved by rest. He is on oral hypoglycemics and statins, but not compliant to medication, and he has been smoking for last 40 years. Pulse examination on the left reveals present femoral, absent popliteal and distal. His right left his right leg revealed intact femoral and popliteal, but diminished distal pulses. See lab results and report. Blood pressure 110 by 70 mm of Hg, heart rate 76 per minute, respiratory rate 18 per minute, temperature 36.6 degrees centigrade, oxygen saturation 95, random glucose 10, HbA1c 8, ECG normal. Which of the following is the most appropriate investigation? CT angiogram, vascular ultrasound, conventional angiogram, magnetic resonant angiogram. A 62 years old male, diabetic and is hypertensive, 4-hour history of sudden left leg pain after 200 meters of walk, relieved by rest, oral hypoglycemics and statins, uh, but not complying to medication, smoking for last 40 years. Pulse examination reveals absent popliteal distal. Her right leg revealed intact. Femoral and left leg reveals femoral absent, popliteal and distal. His right leg intact femoral but diminished distal pulses. Glucose is high and HbA1c. What is the most appropriate investigation? CT angio, vascular ultrasound, conventional angiogram, and most. Ma'am, CT angiogram,
Yeah. Why? Excellent.
ma'am,
Why?
most accurate due to absent
Most,
pulses and
yeah, excellent. Excellent. So, Dr. Hira, nicely done. Thank you, Dr. Hira. So, I have to study the smarter way. What are the smarter way? First of many questions, but initial step, definitive management. These are the, so we have to study the smart way that what they are asking. Initial, definitive, or acute limb ischemia and chronic limb ischemia. We have to understand. Is that acute or chronic? Sudden loss of pulse or 6P present means pulse, pain, paresthesia. History of atrial fibrillation or valvular problem. All are the smarter way to the study. Because why? A patient atrial fibrillation come to your hospital. So what does it mean? There is an increased chance of thrombosis, sudden loss of pulsation. I have to give initially either thrombectomy or start the low molecular heparin. So see, acute limb ischemia, initial management heparin. Initial management. So you can ask me, ma'am, you always say low molecular heparin, so they are stealing this heparin. So what does it mean? Actually, chronic case means what? ICU patient want to stay or have to stay long time, more than 7 to 3, even after admitted the patient in the ICU, you have to give prophylactic low molecular heparin. But thrombosis, like in MI patient, we have to give thrombosis or thrombolysis by tenecteplase or streptococcus. But there's a limb ischemia acute setting. If you ask, I have to do thrombolysis by heparin, because heparin only drug we use during stanting, when we do stent in the MI patient in the heart. Okay, so you can ask me, ma'am, if the option stay in the low molecular heparin. Yes, you have to choose low molecular heparin when, if it is not acute setting duration already passed. So right now, so you may ask, ma'am, acute setting, how I understand, if it is more than 6 hour or 12 hour, so you can't give heparin, or 1 or 2 day already passed, so you have to start low molecular heparin. So heparin only thrombolysis case, I always say just forget the heparin option, because why? Heparin will misguide you. Just for one option in limb ischemia, we will choose heparin for acute setting. Acute lower limb ischemia, initial investigation, Dr. Monia's case, Doppler ultrasound. Doppler ultrasound, not duplex, but somehow some questions, some record they posted duplex. So whatever the Doppler duplex post or answer accordingly, initially we'll do duplex, okay, or Doppler. If chronic ischemia, bilateral lost pulses, sign of chronic limb ischemia. In ischemia chronic, so we have to do CT angiography for doing stanting or bypass according to the report. So chronic limb ischemia, we have to do CT angiogram. So this is why I said this is the study smarter way. Dr. Hira's case, Dr. Hira nicely said there's already past absence of chronic setting, so we have to do CT angiogram. So there is acute limb ischemia setting. So see, heparin and pain management, acute limb ischemia, irreversible, no pass, irreversible damage, gangrene will be started soon. If you don't do amputation, you have to start amputation. Viable with neurological deficit means what? Pulse absent but viable. Pulse absent but viable. We have to do thrombectomy or bypass by doing CT angiography. Vascular lesion present or absent. So if the vascular lesion present, we have to do bypass or we have to do endovascular therapy. If vascular lesion no present, we can give only medical therapy. What is vascular lesion? Means stenosis. Thrombus occluded as stent. In a blood channel, there is a thrombus, and you can't do thrombectomy or thrombolysis. So we have to do surgery or endovascular surgery to pulling out or to the remove the thrombus. But if not so important, we can give low molecular heparin or antiplatelet drug. So if heparin we are giving viable, no neurological deficit, we have to work up regarding the CT angiography, duplex angiography, and we can do revascularization within our thrombolysis or thrombectomy or bypass grafting. So see the scenario. Short, there is a telangiectasia, there is a varicose vein, and there is a skin changes, chronic venous insufficiency. Okay. Sclerotherapy. Sclerotherapy we do in radiofrequency or laser ablation, open surgery in compression dressing for ulcer. Our management according to stage, according to the classification, we have to do manage in the ulcerative cases. First question by Dr. Maha Umar. First question.
60-year-old male patient with claudication symptoms in buttock and impotence and wasting of muscle diagnosis. A. Aortoiliac insufficiency. B. Burger disease. C. Common femoral artery occlusion. D. popliteal artery occlusion. Claudication symptoms in buttocks. And importance and wasting of muscle diagnosis. Ma'am, A. Aortic iliac insufficiency.
Yes, excellent. It's the aortic iliac insufficiency cause the patient symptoms, the buttock and importance, the aortoiliac. Thank you, Dr. Maha. So treatment, we have to do bilateral iliac disease, aorto bifemoral bypass. If it is unilateral, femoral bypass. This management, investigation or treatment is very important. Thank you, Dr. Maha. So second question and third question will be discussed. First question will be discussed with me, Dr. Badhan.
Yes, ma'am. 45 years old woman presented with a non-healing ulcer at the medial malleolus associated with leg edema and hyperpigmentation. Management consistent of wet to dry dressing, split thickness skin graft, superficial perforator ligation, and compression dressing, multiple layers. Non-healing ulcer, medial malleolus, and also leg edema and hyperpigmentation. So I will not wait to dry dressing. It will excluded. Split thickness skin graft. So answer will be split thickness skin graft, ma'am.
No. How? Why not, Dr. Badhan? See, a patient suffering from a ulcer, it is non-healing, a long time.
Okay.
And this long time ulcer already edematous, hyperpigmented means it's worsening. So we can't do split thickness skin graft, we can't do superficial perforation right now. It's excluded. A and C excluded. Either B or C. So compression dressing means multiple layer we have to do for the healing. It's an ulcer. So no need to write now split thickness with graft. Right now we have we can do compression dressing. Okay. Second
Compression
question by
dressing.
Monia Jawan. Yeah, Dr. Monia Jawan, try. This is the exam question. Dr. Monia Jawan. If Dr. Monia is here.
Yeah.
Direct question. Sigmoid dissection best prophylaxis for the DPT.
Just 1 minute, doctor. Yeah. Second question: a patient for sigmoid resection or patient for LAR, what is the best prophylaxis DPT? Sigmoid dissection, that is surgery, so it should be low molecular weight heparin. No?
Excellent, excellent. It's a direct question exam in DHA. So we have to give prophylaxis by low molecular heparin. Thank you, doctor. These two questions here. First question will be discussed with me. Very important exam question. First question, second question already discussed. So first question will be Dr. Madhya Bhatt. Okay. So if Dr. Madhya not here, Dr. Priscilla.
Yeah, yes, ma'am.
Yeah. Madhya is here. Yeah.
56-year-old woman presents to the clinic with a non-healing ulcer over her right lateral malleolus. She is hypertensive but not diabetic. Her pulse is normal and her local examination shows dark discoloration of the skin around the ulcer and a viable ulcer bed. Which of the following is the most appropriate next step?
So unilateral leg erythema, right? And there is
Yes,
an
ma'am.
independent position cold, already done cold, femoral pulse present but already started cold. Means distal pulse can be palpable but not tender. So if I say Dr. Madhya do excluding method, deep vein thrombosis no. Cause why? Because unilateral leg erythema present in dependent position, femoral pulse present but distal can be palpated. It's very rare. Can be palpated but going through absence, but not absent, but it's a very difficult to palpate. So ongoing what?
Ma'am, venous duplex ultrasound.
No. Your question first one. You are discussing second one. No. You are discussing diabetes with unilateral leg erythema, right?
Oh no, the other one.
Okay.
Okay, first one.
You are. I'm this one, right?
Oh no, the other one I was.
Okay, this one.
Yes,
Non-healing
ma'am,
answer.
that
Okay, what
one.
is your answer? Okay, so what is your answer first? Okay, no
It's
issue.
vein.
Venous duplex ultrasound. Your answer, yeah.
Yes.
Yes, your answer, yes, answer. I am thinking the first one. Okay, thank you.
Sorry.
So your answer, no issue. First, on this question already discussed with Dr. Monia. That's why I was omitted. First question, okay, no issue. Your answer is venous duplex. Answer is correct.
Yes.
So first question will be discussed with me, Dr. Dr. Mehis. First question, this one.
Yes, ma'am. Patient with a unilateral leg erythema increases in the dependent position. Cold femoral pulse is present. Distal pulse can be palpated. No tenderness, no swelling, no fever. Otherwise, unremarkable diagnosis. So, ma'am, cellulitis is ruled out because there is no tenderness and no swelling. In superficial thrombophlebitis, there would be pain. Arterial insufficiency.
Yeah, it's the arterial insufficiency cause.
Ma'am, because there is.
Can be. Tell me.
Ma'am, one it is cold and a distal pulse can be palpated.
Yeah, this is the point. This is the no tenderness, which is cold and distal pulse can be palpated. Okay, thank you, Dr. Mihis. You are done. Excellent. Thank you.
Thank
This
you.
way, though, both question or the exam question, this way you have to do performs. Last topic is very important topic, very commonly asking question in the exam. DHA, HAD, just remember shock. It could be hypovolemic, it could be neurogenic, it could be the cardiogenic. So shock. Shock assessment, it could be cold clammy extremity or warm burning extremity. So if it is warm, there is a high cardiac output. In septic shock, high liver failure, antibiotics we have to give. And if it is cold clammy extremity, low cardiac output, but JVP will be high. It could be JVP will be high, low if it is orthostatic like heart impaired hypovolemic shock. So this way we have to do evaluation. In case of cardiogenic shock, we have to assess and we have to treat by in inotrope agent. We have to do echocardiography. If myocardial ischemia, for the low cardiac output, for cardiogenic shock is the cold periphery. For warm periphery, either neurogenic or septic. So now a neurogenic we have to assess for cold clammy extremity is the hypovolemic or it is the myocardial or cardiogenic. So either I have to assess or I have to manage by IV fluid or cardiography, echocardiography, or we have to give the inotrope support for the warm bounding. If needed, the septic or neurogenic, we have to give intravenous fluid. If no improvement, we have to do adrenal crisis, renal heart syndrome, and we have to consider invasive vascular monitoring. Remember this way shortly. Very high yield discharge for the DHA HAD is very important. Type of shock. This is the high yield topic for the exam. Must get a question. Okay, just memorize this way. This chart for the presentation, but this chart very important for the exam. Must to know who's the exam very near. Hemorrhagic shock. Shortly, I myself remember hemorrhagic shock. Only one will be higher is the vascular resistance. Systemic vascular resistance will be higher. Otherwise, cardiac output, oxygenation, central venous pressure will be the lower. Only vascular resistance will be higher. Only one point. Septic. In septic, only cardiac output will be higher. So in septic, I have associated with cardiac output higher and central venous pressure will be lower. Vascular resistance will be lower. So safety, I have to remember one point is the cardiac output will be the higher because there will be the tachycardia, tachypnea, okay, cardiogenic. Cardiogenic all will be lower except central venous pressure because we have to do monitoring who are working the cardiology. We have to assess central venous pressure, it will be the higher. Neurogenic all will be lower except oxygenation will be the higher. So this way adrenal insufficiency is not important, pulmonary embolism is not important. Just should remember that adrenal insufficiency and pulmonary embolism, oxygenation will be the lower. But important hemorrhagic, septic, cardiogenic, and later I'll discuss 3 questions. And there is a full chart, just remember after my session. The first question, one by one. First question will be discussed with me, Dr. Reza Uruzi. First one. First question, this one. Don't do wrong. This one.
Yes, ma'am. Yes.
Mhm.
Patient post-operation abdominal aorta repair become unstable even with fluid replacement and have negligible urine in catheter, decreased vascular resistance, and increased cardiac output. Cardiac output increased, then it's not cardiogenic shock, and urine output decreased, and fluid replacement also urine output decreased, then it can be it's not anaphylactic shock, it's not cardiogenic shock, then it must be a hemorrhagic or septic shock. And because of hypovolemic, because of decreased urine output, it must be hemorrhagic shock and hypovolemic shock also. Option B.
Negligible urine in catheter.
Yes.
Patient unstable, fluid replacement you started, negligible urine catheter, decrease not, your output is not decreased, Dr. Reza, you read wrong. Negligible, you read wrong. You again assess the case.
Then resist
No.
vascular.
The again read the sentence because you read wrong.
Okay. After operation, repair become unstable, even with fluid replacement, and have negligible urine in the catheter. Decrease vascular resistance. Oh, decreased vascular resistance means neurogenic shock or septic shock. This is septic shock.
Yeah. So what you done wrong? You mean urine is negligible? No.
Yeah.
Urine present, output okay, but it is decreased vascular resistance. Increased cardiac output, it is septic.
Septic shock. Yes. Thank you.
Second question, this one. Dr. Kishori. This is question 2. Okay, don't do wrong. Question 2.
A patient presents to the emergency department with paralysis of all four extremities after being involved in an automobile accident. The patient's extremities are warm and pink. Which of the following is the most likely diagnosis? Hemorrhagic, irreversible, neurogenic, cardiogenic? Because warm and pink, it is related with neuro and septic shock. Ma'am, this is the neurogenic shock. Because
excellent. Yeah, it's the neurogenic. Okay, thank you. Third question by Dr. Rehana. This one. Dr. Rehana is not here, right? Okay, no issue. So this question will be performed by Dr. Saba.
Male, 30 years after road traffic accident, came with a distended abdomen, tender and cold limb. GVP is flat. Blood pressure is 80/50 and heart rate is 137. Ma'am, it is a having history of RTA and JVP flat and distended abdomen. So it may be hemorrhagic shock because having a history of road traffic accident.
Yeah, excellent.
And blood pressure
So
leading to
yeah,
decrease.
BP is leading to dropping. Yeah, excellent. So today my surgery session ended. So I hope all enjoyed. Thank you, my dear candidates. I hope my course is enjoying all. So every question are very important. I will post the PDF and recording. It will take time. But this PDF, I already said the orthopedics is plus minus if you can study is enough. But no, it's not necessary. But the hemorrhagic shock structure last point vascular surgery is important. You have to must read. Okay. And the question I posted here, must read. So thank you, my dear candidates. Assalamu alaikum to all. Good night to all.
Okay, thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.